Please give a warm welcome to Dr. Stephen Ansel from the Mayo Clinic.
All right, well, good morning, everybody. Thank you very much for being here, and thank you for inviting me, and I'm delighted to be part of today's presentation. And so what I'm going to be doing is talking a little bit about the overarching themes that you're going to be hearing through the weekend, specifically talking about the roadmap that you've been hearing about, these different pathways that have been highlighted as research focuses that we'd like to, as a community, be encouraging research to focus in on each of these pathways. So I think what I'd like to do as we get started, and many of you are previous attendees and some of you are new, and the goal is to bring us all onto the same page. The goal is to let everybody understand what we're talking about, introduce and highlight some of these issues related to these pathways and roadmap that we are highlighting, and then really just make a clear case for why this is important to you, how this is actually helping patients in the real world. So my goal today is really to highlight 4 different areas. And as I'll mention in a minute, we'll get into the roadmap details as we go along. But the first thing I wanted to do, many of you have some degree of knowledge about Waldenström's. Some of you are very knowledgeable about Waldenström's. Some people might be brand new. My goal is just to take a few minutes, build on what Dr. Mattis already discussed for the first timers earlier today, and get everybody kind of up to speed on what exactly we're talking about when we're talking about Waldenström's and what exactly we're talking about as far as the spectrum of how those diseases can look. The second thing is then say, well, as we look to the future and say, how can we make outcomes for patients better? This roadmap that experts together have suggested, what is that? Exactly what are we looking for? How are we going to achieve things, and how might that benefit someone like you? My charge is then to talk about one of those areas, and we're going to talk about why the bone marrow, what we call microenvironment or neighborhood, matters and how that might be important. And I want to end up with the fact that just utilizing that as the first of the areas that we're talking about is show that that's important because it actually is translating into treatments for patients like you. So starting us off with what exactly is Waldenström's, and many of you would go, well, I got a good handle on this. So I just remind you that actually everyone with Waldenström's really has 2 problems. You have the problem in the bone marrow or your lymph nodes or your spleen, which is this lymphoplasmacytic infiltrate. In other words, there are cells present, and too many of them, in the bone marrow, sometimes in lymph nodes, sometimes in spleen, and they, by their presence, can cause a bunch of problems. The second one is the one that you'll hear a lot talked about, and that is the protein that's made, the M protein or the paraprotein or the monoclonal protein. And what is that? These cancer cells are making a useless protein, but the protein isn't non-functional, it's just not helpful. And when I say it's non-functional, it doesn't target antibody or bacteria or like it should. It starts to do all kinds of things that are unhelpful, like stick to your nerves, clog up your circulation, cause anemia, and a variety of other problems. And the essence about this protein, as you can see there, it's kind of got 5 fingers. It's a very big protein. It's 5 antibodies glommed together. And so because it's big and its job is to stick to things normally, it sticks, unfortunately, to many things. And by doing that, can cause the viscosity problems. And I'll talk about that in just a second. So the first of the 2 problems that people with Waldenström's have is this infiltrate of what's called lymphoplasmacytic lymphoma. And if you look at this picture, you can see there's some arrows that are highlighted there. So I'll just point to them over here. And you can see that there is a cell with an arrow there that kind of has its little nucleus off to one side. And that is a plasma cell. And that's the cell that most typically will make antibodies. If you look carefully, you can see there are some of these bigger cells, but then there are some of these smaller cells. And the smaller cells are the lymphocytes. So that's where the name lymphoplasmacytic lymphoma comes from. There are 2 different sizes of cells. You're going to hear a lot more about our understanding of these cells. We've learned a lot about their genes. We've learned a lot about some of their genes being messed up. And when it's messed up, it causes some of the signaling, and I'll talk about that in a minute, to be out of control. But the problem is these cells start to fill up the bone marrow, and as it fills up the bone marrow, it crowds out the good cells, and people can become anemic, their platelet counts can go down, they can start to feel increasingly tired, and a variety of other problems. Interestingly, if you then say, well, an average patient showing up, how do patients with Waldenstrom's present? What are their typical symptoms? And I want to highlight this study because it just shows you that there is a huge spectrum. And I'll talk about the fact that not all Waldenstrom patients are created alike. So the first thing is about a quarter of patients have no symptoms, and it was just a surprise finding. They had a blood test done, something looked a little funny, they checked the proteins, and lo and behold, there was this elevated IgM, and they were told they have Waldenstrom's, but they really would not have known it, not for a minute. Secondly, you can start to have some of these problems. So anemia being a very common presentation. Hyperviscosity, you'll hear more about, is when your blood is pretty thick, and because it's thick, it kind of plugs up the circulation, and you can get all kinds of problems from that. B symptoms are what we kind of collectively call things like fevers and sweats and losing weight and the like, and that's just because these cells are very activated and are actually kind of poisoning your system. And then that extra protein will mess with your coagulation, and people can get really significant bleeding problems, and obviously the kind of clogging up your circulation can cause neurological problems, which cause people to have trouble thinking straight, and people can have a lot of visual problems and the like because of this protein and this bone marrow infiltration. So the point of this slide is to show that there is a very broad spectrum of people with no symptoms to people with pretty bad symptoms, all that fall within the diagnosis of Waldenstrom's, and in a minute I'll explain to you why that matters. So I mentioned to you that there's this really big protein that is the monoclonal protein, or the paraprotein that everyone is talking about. And as I said, it has 5 antibodies stuck together. So the reason this matters is that if you walked out of here and somebody coughed on you and you got an infection, the way in which your body deals with it is that those lymphocytes turn into the plasma cells and start to make proteins, and the first protein they make is IgM. And IgM is what I would call the quick and dirty response. It's big, it sticks to lots of things, it has lots of little parts that can grab onto viruses, and so by its nature it's a very useful protein, except when you're making far too much of it and one that's not targeting anything specific. Then the problem is all these sticky edges here start sticking to the wrong thing, and that's where a lot of the symptoms come from. So you go, well, tell me a little bit more about those symptoms, and many in the room might even have experienced some of them. So here you can see somebody who has what we call Raynaud's phenomenon. So they will tell you that their blood circulation to their fingertips is such that if they put their hand under cold water, or it's a cold day in Minnesota where I'm from, and they walk outside, immediately they would get their fingers turn all white, just like you see in this picture here. You can see this person has all kinds of leg ulcers, and what's happening here is the circulation is no good, and this is what we call a watershed area where the blood supply is not that great, so no good delivery causes the ulcer problems. This is an MRI scan of somebody's head, and you can see lots of white stuff here, and the reason is that not enough blood supply is getting to that area, and this person is very confused because of the fact that their brain is malfunctioning from kind of thick blood that's plugging up the blood vessels. And you'd have to look very carefully here, but here is the back of somebody's eyeball, and what you're seeing here is that there is what we call sausaging. So the blood vessels kind of have little lumps in them, and you can almost watch the goop, if you like, sort of just sliding through these blood vessels because the blood is so thick. And if you look very clearly, you can see there's kind of red spots here, and that's actually some bleeding and oozing in the back of the eye. So a lot of patients can have a lot of eye problems, and all of this is related to the over-viscosity that's going on in patients with high IgM levels. The second problem with these sticky blood is that it actually goes and it sticks to places that is not very helpful. So if you might not be able to see this all that well from the back of the room, but this person's shins have all kinds of little lumps on them. And if you take a biopsy and look under the microscope, there is a whole bunch of protein, and this is called amyloidosis, where there's actually protein deposited in the skin, and it can be deposited anywhere. It can be in your kidney or in your heart, and obviously that can cause significant problems. And the last thing that you can get is that what happens is these cells stick to red cells, or the protein sticks to red cells. So here you can see a red cell, there you can see the protein, and it causes red cells to stick together. And your spleen is a kind of a quality control mechanism, and it hates that. And so it takes those cells out of the circulation, and people can get what's called a autoimmune hemolytic anemia, which is basically breaking down your red cells because they're sticking together. So the reason for highlighting this is just to remind you two problems. Too much infiltration of these cells in the bone marrow or lymph nodes, too much protein in the bloodstream. Too much in the bone marrow can cause anemia and other problems. Too much protein in the bloodstream can cause problems just by the viscosity issues or sticking to things, and all of those result in people having Waldenströms. But what I want to highlight is that that's on the one end of the spectrum. Those are the people that have a lot of symptoms, but you saw at least 25% of people have no symptoms. And so actually there are three groups of people. And so this highlights the fact that you can have people that we would call Waldenstroms, and those are the people that have a lot of those kinds of symptoms. But you can also, and you heard people talk about this, MGUS, a monoclonal gammopathy of uncertain significance. And what that means is we found the protein, but there really isn't much else going on. And the question is it going to really turn into all of those symptoms or not? And I'll show you in a minute that the answer is maybe not. And then you can have people that have what we call smoldering Waldenstroms, which means, yeah, they got enough protein and they've got a bunch of bone marrow involvement, but they really don't have that much in the way of symptoms, and none of these things that I mentioned are actually happening yet. And so because of that, those patients may take years to actually develop something symptomatic, and you've actually saw patients getting up and saying they've had this for decades. And so many times they can be in what we call a smoldering group. And the good news about that is you don't want to jump in too soon with treatment, because patients may actually do very well without it. And this is what this shows, that if you take those group of people that have the smoldering Waldenstroms and you compare it to people that have, or just in this case look at the IgM MGUS or the smoldering Waldenstroms or the indolent Waldenstroms, you can see this MGUS. This is what we call a Kaplan-Meier curve, and as people have problems come up, they have a little step down in the curve. So what this means is that if you say, well, the people that had that MGUS, did it turn into something? If you look over here, this is out many months. We're talking here 144 months. This is 12 years. More than 80% of the people that have this MGUS haven't actually got anything yet. So very important to see, and even the people that have the smoldering, if you said, what time did it evolve into real symptoms? You can see that here again, out at 10 or 12 years, more than half of the people still haven't really developed something significant. So why does that matter? Well, if I treated a patient who had these two processes somewhere over here, I'd be slapping them on the back and saying, what a fine job we did. Well, bottom line, we've done a fine job anyway without my help. And so important to know that this can be very different in how this may behave. And in contrast, here's somebody who has full-blown Waldenstroms, and you can see this line to something bad happening is much more straight down. And if you look here out at 10 years, you can see more than half the patients have run into trouble. So very important to work out who has the very mild MGUS smoldering, who has the more full-blown true symptomatic Waldenstroms, who can be waited on, who needs treatment. And that's why understanding the biology and doing this whole roadmap thing really matters. Because we need to understand how people land in each of these categories. We need to understand how best to treat each of these categories, because this is not a disease where one size fits all. So this gets to the point about the Waldenstrom's roadmap and why we need it. So in essence, as I said, we have a disease, many of you have first-hand experience with it, that has a wide spectrum of symptoms and a increasingly good understanding of what's happening, but still a lot that we need to learn about how we can really define who's in what group and what's the best treatment to give each patient. So this group of experts that sat down a year ago and then just recently met again keeps revising what are the key issues that we need to really get our heads around so that we can honestly answer some of the important questions around disease biology. And there are 4 groups, and I'm going to just highlight what they are, but you're going to hear this weaved through the whole weekend talking about these different pathways that are part of the roadmap. So you can see, here's clearly a map where these guys look kind of puzzled, but the hope is that we're actually doing a better job of saying what are the priorities. So the 4 priorities that you're going to hear a lot about, Firstly is signaling, and I'm going to in a minute just go through what each of these exactly are. Signaling has to do with how the messages travel through the cell that tell the cell what to do. So it is really kind of focusing right in on the tumor cell and how it gets told whether it should be growing or whether it should just be sitting still. The second is what we call omics. Now, omics is just a way to put a whole bunch of things into one big group. But as you'll see in a minute, we understand a lot about the genetics. But the genetics are only the first step. That's sort of like, if you like, the hardware. And I'll show you this in a minute too. The question is, how does that translate into how the cell behaves? And so that whole understanding has to do with the genomics, the transcriptomics, the epigenomics, the metabolomics. It all has to do with what it's doing downstream. And putting that all together is actually a very important area. The third area that's important is immunology. So what does that mean? That just is, why did your tumor get away from the immune system? The immune system has kind of gone to sleep on the job here. Got a cancer cell, job of the immune system is to take that out. How come it's just letting that happen? Why is it not targeting the tumor much better? And how can we wake it up and focus it in on doing a better job? And the last thing is, which I'll touch on a little bit more detail here, is the bone marrow microenvironment. What that means is, why does Waldenström's like the bone marrow so much? Why doesn't it just stay in the blood? Why doesn't it go to the lungs? Why doesn't it like to be in the bowel? Why the bone marrow? Well, clearly it's getting something helpful from the bone marrow. The bone marrow is a facilitating environment. Question is, how can we disrupt that? How can we make it unpleasant for a Waldenström cell to live there? Because clearly that would be beneficial. So those are the 4 areas that are felt to be the priorities, at least for the foreseeable future. So I want to take each one of these in turn. So on the left, you can see a figure, and there's going to be a test about this afterwards, so I'd like everyone to memorize this. But you can see that signaling in cancer is unbelievably complicated. There are all these different pathways, and if you can imagine, signaling is like the wiring in your house. It's how all little different areas, switches, get to kind of talk to each other, get to tell the cell what to do. And clearly this can be unbelievably confusing. However, I tell you that you deal with this every day. You know, if you live in New York, if this is an underground in London, you know, a complicated network is actually quite clear once you actually have a map and a clear kind of plan and know where to get on and know where to get off and know when the message or this train in this case is coming by so that you can get on the right one and go to the right place. So the goal of understanding signaling is to make a more definitive map of exactly what all that spaghetti kind of looks like. And you're going to be hearing through the weekend different ways in which we've understood quite a lot. So you could argue that right now we have a few of the train tracks well mapped out. There are a few others that still look a little spaghetti-like, so clearly we need to get them mapped a little better. But the hope would be that at the end of the day, the signaling pathways are quite clear, and when you need to do one thing, you'd get on this line, and when you need to do that thing, you get on a different line, and it would all be a lot more clear as to exactly how to use the signaling in a way that benefits patients. So the second question, as I touched on, is this whole thing of omics. So again, if you can read it from the back, here's this sort of gene with a little map. They're going, do these genes make me look fat? And you go, that's such a pathetic little joke, but the point is it's actually a lot closer to the truth than you imagine, because actually how genes translate into proteins and how proteins are used is what defines how the cell behaves. So actually, your genes do make you look fat. Or maybe you're fat and so your genes don't look good on you, but still. I've always learned this is a question never to answer, just kind of look dumb and sort of confused, because if you answer it, the answer is never correct. So how does this work? So again, if you can imagine, a lot of work, and you're going to hear about mutations and things that we know at the gene level. So we've worked out that there are genetic mutations, MYD88, you're going to hear a lot about, CXCR4. These are genes that we know have a change in them that is specific to Waldenström's. So that's really important. The point being is that there's a lot that happens beyond that we still have to understand. So genes are transcribed. In other words, you make a copy of it. Then once it's transcribed, you make a protein out of it. Then the protein has to metabolize or be changed to become active. And then it has an effect. So just what happens at the top is only kind of the beginning. So I try to make an analogy here that I heard that I thought was quite helpful. This is the same thing like your computer. If you buy a new computer but you don't load any operating system and no software onto it, well, you bought yourself a very expensive doorstop because it does nothing. So you need an operating system. Then you've got to load some software on. So in this case, we put on Flash, Adobe Flash. Then you can run a program like YouTube, and then you can watch your favorite cat video. So bottom line is, for us to understand this part, we've got to have all of these parts. And in Waldenstrom's, we're kind of a bit back here. We understand the hardware has got some issues, but we don't understand entirely how that's going to mess with my ability to watch my cat video. So that's where omics comes in, is to understand each of the levels as you kind of step down that process. The third area that we're going to talk about over the weekend is immunology. So again, if you can read from the back, it's the doctor saying to the patient, according to all our tests, your immune system is out to lunch. And in some respects, in Waldenstrom's, that's true. Immune systems are out to lunch, and they're out to lunch in many ways. They're out to lunch because right inherently, they let a cancer cell slip by and didn't take care of it. But they're also out to lunch because we do all kinds of nasty things that mess up the immune system. And even when we use what we feel is kind of easy treatment, like rituximab, for example, that also messes with the immune system. So really understanding how best to optimize the immune system so that we can get rid of the cancer cell, because we've got one extra little wrinkle in here, and that is that the cancer is part of the immune system. So again, when you're trying to target the immune system to do good things, you've got to make sure you don't help the cancer cell do bad things. So all told, it's a complicated discussion, and that's an area that's felt to be important in understanding where we're moving to next. That's just really kind of highlighted in this cartoon here. So again, I don't expect folks to know everything, but here's the cancer cell. Here's what we call the effector cell. This is the cell that does the killing. And we'd like to have a really good directed killing effect from the immune system. But there are lots of other normal cells that are kind of getting in the way. And sometimes the cancer actually hijacks the normal things by causing normal suppressive elements, ways in which the immune system gets switched off to get optimized and what we call upregulated. And that basically takes that effective kill the cancer message and dumbs it down. So how do we find the sweet spot between keeping the cancer cell targeted, but not at the other hand having an overproductive and damaging immune system or an ineffective one? And lastly is the bone marrow microenvironment, and that's what I'm going to talk about. So, you might have heard the little saying that a man is known by the company he keeps. Well, in some respects, in Waldenstrom's, the bone marrow is kind of like bad company. There are a bunch of cells that are in there that are clearly facilitating bad behavior. And our reasoning when we think about how to change the microenvironment is to go, how can we get rid of those factors that are influencing this cancer cell to behave in a bad way? And this just, again, has lots of arrows here, and I don't expect people to be able to work out what that is, but what I want to point out is that many, many, many different cells are present in the bone marrow. The bone marrow is making blood, it's making platelets, it's doing a lot of other things, and it's helping the Waldenstrom cells survive. So you have to find out how on earth do we find ways to keep all the good things the bone marrow is doing going, but on the other hand, stop it from doing the bad things that it's doing to facilitate the growth of the cancer cells. So again, 4 things I hope you heard about. Signaling, how to make the messaging appropriate. Omics, how do we understand the genetics and translate that into the effective proteins, because that's what it's all about. Immunology, how do we make the immune system just go after the cancer, but without stimulating the cancer, which is part of the immune system. And finally, how do we clean up the neighborhood? Because the bone marrow microenvironment is unhelpful and is actually facilitating bad behavior. and how can we change that? So in the last few minutes here, just going to give you a little bit of insight into, so what's so bad about the neighborhood? What's unique about the bone marrow microenvironment in Waldenstrom's? And I'm going to try and kind of pull the themes together a little bit, because one thing I don't want you to leave with is to think that each of those 4 categories is entirely independent of each other. So remember my image of all of those pathways. You could see how they all are, like spaghetti, very interconnected. Same is true with even each of these 4 themes. They have significant connections and overlaps. So again, during the day today and tomorrow too, you're going to hear a lot about genetics, and you're going to hear a lot about MYD88 mutation and CXCR4 mutation. And that's shown here, and it doesn't project that well. But from the outside of the cell, there is messaging that goes down to the nucleus. So the environment is talking to the genes, and this mutation that is in the genetic pathway is what's actually very typically seen in Waldenstrom's. But rather than just thinking that's the only thing and you just have a genetic abnormality, the interesting thing is that amplifies a lot of the messages that are coming in from the outside of the cell, and by doing that, causes the cell to make all kinds of extra proteins that it really shouldn't be making. Similarly, you're going to hear a bunch about CXCR4 mutations. So just to remind you, what is that? Well, it's actually a way in which the cell can hear from the environment around it and gets told where it needs to be. So it's actually what is called a chemokine receptor. What that means is it's a homing device. It goes in the direction of wherever the signal is coming from. Now it has a mutation in it, which means it's no longer operating normally. But again, remember that although we think that's a genetic event, it translates into how the cell behaves in the environment because it's responding to the homing signals. And so when you have mutations, the response is not normal. And why that matters, if you look to see how cells behave as far as their ability to actually survive or migrate or adhere, in other words, stick onto other things, you can see that if you compare the ones that have the mutations compared to the ones that don't, the ones that have the mutations grow much better and really don't pay attention particularly much to where they're supposed to go, but they adhere and get all kinds of beneficial messages from the places in which they attach. So understanding how to get the positive message and decrease the negative message is really going to be important for the future. And does this matter in real life? Well, it turns out that it seems like whether you have mutations or you don't have mutations, and which of the mutations you have, cause a different outcome for patients. So there are some patients who have excellent outcomes and clearly others that do much worse, and a lot of it has to do with which of these mutations are present. And so I would remind you that this is important across the board because it also matters as to how you respond to treatment, and you'll hear that, for example, efficacy of ibrutinib can be different by whether you have these mutations. And this just reminds me again to tell you that it's all about connectedness. So you're going to hear a lot about this MYD88 mutation, and it has to do with this pathway from toll-like receptors. But toll-like receptors are the way in which the cell talks to the bone marrow microenvironment, and the thing that it does in response to this is make cytokines, and cytokines are another way in which the bone marrow talks to itself. So a lot of these things are very interconnected. So for the last few minutes, I just want to share with you about how messed up the bone marrow microenvironment really is. And there's a lot that we need to learn. So we started off just saying, well, let's understand all of these messages and all of, so we say, how toxic is the microenvironment? How toxic is the neighborhood? How many bad elements, if you like, are living in this neighborhood? And so we looked at 30 different cytokines. Now, cytokines are proteins that tell cells what to do. So we just wanted to know, compared to normal, are these more or less? Are they getting told to do certain things versus other things? And you can see here that depending on how we wanted to cut things, there were significant differences in a variety of these different proteins when we compared Waldenstrom's patients to normal controls. And it was very interesting to go, well, which of these ones really matter? And the way to do that is to say, well, cells that matter to us in this disease, these lymphoplasmacytic cells that talk to other cells in the neighborhood, what proteins might they care about a lot? So what you're seeing here is that if you take a B cell, it interacts with other cells like T cells, and when it gets activated, it either starts making protein or it becomes a memory cell. But you see I circled here a bunch of different proteins that we just showed are abnormal in patients that have Waldenströms that obviously are going to influence how this cell behaves in response to this interaction by either making too much antibody or becoming a memory cell. So our feeling was that if these are abnormal, clearly it's being driven in this direction rather than in this direction. And that creates an opportunity for us to treat patients and improve things. So the first protein, many of you that have been to previous meetings will know that I've spoken about this before, is a protein called B cell activating factor or B lymphocyte stimulator called BLyS or BAF. And basically all I want to show you here is that, one, you can detect it at much higher levels in Waldenstrom's patients than normal. You can see that it binds to the cells. That's what these little peaks are here. And if you actually treat cells with this protein, these are Waldenstrom cells, they grow much better. So clearly this is an important protein. We know the levels are much higher in Waldenstrom's, and so having extra of this protein around is causing these cells to grow and make much more IgM. There's a second protein called IL-6, again one of the ones that's significantly higher, and this story is the same. This brown staining you see is the IL-6 levels are very high. You can see that the cells bind to it. These little peaks that move over show you that the signaling gets switched on, and you're seeing here increasing IgM as you have higher doses of IL-6. So again, this protein also plays a role, and I'm not going to show you because it ends up being kind of complicated, but IL-6 and BLyS or BAF together are working together to actually make the whole growth of Waldenstrom cells much more rapid than normal and the production of IgM to be much higher. And there's yet one more protein that really matters, and that's something called IL-21, and the story is exactly the same. More of it in the bone marrow, increasing amounts of it make the cells grow better or make them make more IgM. So again, sort of a constellation of bad actors, all of which are making the environment unpleasant if you're trying to clean it up, and because of that they're actually driving these cells to grow, and that's what fills up the bone marrow and make IgM, and that's what causes all those symptoms we spoke about right in the beginning. So this is just a little cartoon that kind of highlights that, and I think what I want to stress to you is that these proteins don't just come from the cancer cell. Here is the cancer cell. There's a different protein called RANTES that it makes that activates the microenvironment cells, the other cells in the bone marrow. They make all of these cytokines that then reactivate the cells. So there's kind of like a little bit of a give and take going on here, where the cells are helping to activate the microenvironment, and then the microenvironment or the bone marrow environment is feeding back to activate the cells. So this is kind of an unholy alliance where the cancer is kind of working with the environment and the environment is working with the cancer, and so within that bone marrow they've got a kind of a good thing going, and one of the goals is to disrupt that and to understand it better. So again, just to show you why signaling and all of this matters, this is a little cartoon that shows you a simplified version of that one spaghetti drawing that I showed you. But here it is, different pathways that are really important. Not going to get into this, but what I want you to see is that every one of these boxes is a drug that's actually available or being tested or in development for Waldenstrom's. And it's looking at different ways to mess with that kind of messaging system that's coming from the bone marrow into the cancer cell and activating the cancer cell. And in the last few minutes here, I just wanted to highlight about how that's actually making it into real life, to right where you are. So the first one is one that you're well aware of, and that's ibrutinib. So ibrutinib takes the activation that happens from the bone marrow of what's called the B cell receptor. You see the B cell receptor then get activated, it recruits this BTK molecule. Similarly, if you get messaging through what's called the toll-like receptor system, it recruits this BTK. So ibrutinib is a BTK inhibitor. It just stops that. So it's a little bit like somebody's come into your house and is repeatedly ringing the doorbell. and this ding, 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 ding is now driving you nuts. And so you're getting all frantic inside your house. So the same thing is kind of happening into the cancer cell. The ding, 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 ding has now got the cancer cell all riled up. It's growing like crazy. It's pouring out IgM, anything to stop the dinging from stopping, just to make it go away. So if you cut the wire and the thing doesn't work anymore, well, the cell kind of calms down. So that's what ibrutinib does by inhibiting that critical pathway. And as you know, it's a highly effective therapy because of that pathway being really important. A second one, and again, you'll hear more about this in time, is what is known as IMO 8400. And what this is, remember I mentioned toll-like receptor, and you kind of went, "I never heard of that." Well, toll-like receptor is what works through MYD88, and it has to do with that dinging doorbell, if you like. Well, there's another way. You could just stop this little doorbell and just jam it. So don't have to cut the wire, just jam the bell, or just stop the button from being pressed. And so that's what this drug does, is it just stops you from being able to press the button and takes away the message in exactly the same fashion. Third option is to say, well, how about we go way down, right to kind of where the actual doorbell machinery is, not the wiring to it, but the actual doorbell itself, the part that makes the ringing sound. Let's just mess that up. That would also stop the frantic kind of ringing that's going on inside the cell. And this is a drug called everolimus, and that's actually a study that's been done in the past that showed that this is a very effective therapy. And now there are a variety of other agents that are targeting the same thing, and another one is called idelalisib. And this just highlights the fact that a variety of different lymphomas were tested with this drug. This drug is called a PI3 kinase inhibitor, and mainly if you could just focus right in over here where it says LPL Waldenströms, you can see a small number of patients were treated, but they had a very high response rate, and so this is another agent that looks very promising. But the goal of just showing you these 4 different drugs is to say that all of this detail about bone marrow microenvironment, signaling, omics, and immunology is actually beginning to come to therapies that you'll hear more about. These are the newer therapies that are being used for Waldenström's. So to finalize here, just to say, well, what are we learning about all of this? There's a lot of information around these mutations, and you're going to hear a lot more about that this weekend. But these are mutations that transmit messages that come from outside the cell. So it isn't just about the cancer cell, it's about where it lives and the messages it gets. And we know that those cells respond by growing and making lots more IgM, and they do that in response to all of these proteins that are present in the environment, in the bone marrow, particularly these called BLyS, BAF, IL-6, IL-21. And so if you could actually change that environment, change the signaling, change the downstream effects of the genomics or omics, or change in which the way in which the immune system goes after the cancer, we might actually go from just controlling and treating Waldenström's to curing it. So our goal is to move from control to cure. A lot of progress has been made, but the goal is now to take these 4 themes for the roadmap and go to the next level and actually push it over the line, as it were, and get rid of this cancer entirely. Because the day that happens, we'd go right back to the beginning, which I mentioned, is to have patients that we'll watch and wait will be done. Because if we know we have a curative therapy, we'd be right on it right away. But right now, where we have control as our best strategy, if it doesn't need to be controlled, you can wait until it does. But we're hoping that the day is not very far away, where cure is the goal, and in which case the moment it's detected, you're going to be right on top of it to get rid of it entirely. So with that, I'll end, and I just wanted to thank the IWMF, because funding from you folks comes to our lab to do the work, and I'm listed here the people that really do the work in my lab, and so thank you for your time.
Yes, my question was, you were saying there's a foreseeable roadmap where there'd be a cure. I suspect that's an unknown date, but in your professional estimation, do you see 3 years, 5 years? What would your view be?
I think it's a good question. It's a hard question. But I think if I was to throw my mind or cast my mind back 10 years ago and think about what we knew about Waldenstrom's and how we treated it, then cast my mind back 5 years and now to today, and look at how the progress has been made, the number of new therapies, the number of therapies now specifically approved for Waldenstrom's, I think we could say that the trajectory has gone up dramatically. I guess it's challenging to say, could I promise a cure in 5 years? I don't know that, but I will say this much based on how much we know and how the progress is moving. My optimism is very high to say that we are making rapid progress, really profoundly important for patients. And so I would hope that within the time I have left before I retire, we will actually get to the point where we are curing patients with Waldenstrom's. Exactly when that date is much harder to tell. And I've learned in the past that every time I say it's going to be like that, it never is. So maybe it's best not to say that, right?
Thank you.
I'm sorry, I couldn't hear that?
I said, when are you planning on retiring?
Got 10 years to go.
That was an amazing presentation, very informational. It was awesome to get info from you directly from the source. So thank you for that. My question is, at the very end, when you talked about your optimistic hope for an actual cure, what is that? What would that look like? Is that a genetic therapy that you would give to the patient? And what form would it take? Is it a pill or is it some kind of transplant? Like, what are we talking here?
Yeah, so that's a very good question, and the answer is I don't know. But the reason you saw 4 pillars, if you like, or 4 different areas, is that those are intersecting areas, but they're all important. So we've done a lot of work in genetics, and I think we're realizing that downstream of genetics also matters. There's a lot of work, and again, if others follow other kinds of blood-related cancer, a lot of promise with immunotherapy right now. So that's a very promising area. Similarly, there's a lot more known now about signaling and ways to effectively change that.
But that's more of the keeping it at bay type of therapy, not cure, right?
Well, so here's the thing that I think is interesting is the rest of you as a patient is still fully functional and operational. My view is that we just have to tip things in a way that the cancer cell now has a disadvantage and you, the patient, have an advantage. Because your immune system, your body functions can really kick in and normalize, and when that happens, it can make all the difference. So I don't know that we just have to control things. We may just need to change the balance sufficiently that you can take back over again. And if that's the case, we could cure patients without needing to do something unbelievably dramatic. The point is that I think to date we just haven't worked out exactly what that is. But in some respects, I mean, transplant tries to do that. It just sort of reboots everything and hopes that as it comes back in a more favorable way. I think we'd like to be a little more sophisticated than that blunt instrument.
The bone marrow transplant?
Correct.
Yeah, okay, gotcha.
Dr. Ansel, thank you for your very excellent presentation. It's very understandable. But of those 4 drugs that you mentioned, they mess with the signaling. That's what you told us. Seems to me they're not getting rid of the malignant cell. As a result, you got to keep taking those drugs to keep messing with the signal, to use your terminology. It's not removing those cells from your bone marrow. They're still there. There's going to be fewer of them because they're not multiplying as fast. But they're still waiting to start churning out more IgM if you stop taking those drugs. Am I on the right track, or is this
Yeah, so I think what's really critical as we look to the future, and that's again why 4 tracks are so important. One thing I don't think is going to fix it. So this focused on one thing. That's, the signaling part of things coming from the bone marrow microenvironment. However, you could imagine that if you dampen the cell down so that it stops making a lot of the things that are stirring up the whole environment, so things got a lot quieter. And then you actually did something, let's say, from an immunotherapy perspective. You juiced up the immune system. Now the immune system's got much more of a better fighting chance. I mean, I joke and tell people, it's all fine and well to take an immune system and juice it up and then set it loose. But if you set it loose into a very hostile environment, that's like sending 20 crack troops into a whole chaotic city and say, take care of things. that's an overwhelming possibility. You can't do that. But if you could make everything calm down and actually just send in a kind of a critical cohort of soldiers, they might be able to take out the head guy and disrupt the whole thing and win the battle that way. So in some respects, my hope is that we'll be able to shut down the cancer cell, optimize the immune system, change the microenvironment, shut off the signaling, and when we do that constellation of things, we'll take it from a hyped up, kind of boiling over pot and suddenly take it down to normal, that we can take it off the fire entirely and throw it out.
So that's great. So you're essentially saying that these disruption of the signaling pathways might be a frontline treatment, then you come in with your izosimid, Rituxo, or something like that, and do the final wipeout, right?
So I think right now we're still learning exactly what are the order of things to do things in. And so that's where my personal view is that I think the moment you say I've got it worked out, it's a little too simplistic. I think all told though, if we know exactly what we get out of each of these agents, we can then put them in a constellation that really makes all of the difference. Give you an example just about how we're learning about things. So in the world of myeloma, immunotherapy as a single agent using a drug called nivolumab, which is a PD-1 targeted therapy, 0 responses. Standard, just stable disease, no responses. People went, that didn't look very good. Then they combined it with using pembrolizumab with a combination that's very commonly used, the lenalidomide or Revlimid plus dexamethasone. 80% responses. So suddenly it went from like nothing's going on to, whoa, that's pretty cool. So how did that happen? Well, the one set of drugs are working on the tumor cell. The other drug is working on the immune system. When you shut the tumor cell down and got it quiet, the immune system could wake up and do more. So a lot of this has to do with balance, and sometimes things work well in one context and not well in others, and vice versa. So it all comes down to really understanding how to put this all together and not just assuming that if you see one thing in one context, that's going to be the final answer. Go ahead.
Recently, I read about rebuilding chromosome caps called telomeres and helping blood disorders. Anything in that direction?
Yeah, so telomeres are kind of at the end of your chromosome, and it's a way in which you can tell how worn out your chromosome is. So if you can then rejuvenate or revitalize it, it can allow for cells, and it can go two ways. Sometimes you might want a cancer cell to run out of juice much sooner and actually die off, versus on the other hand, rejuvenate cells and kind of take them back to normal. At this point, that's not something that's really been that useful yet in Waldenström's. So there is a lot of research going on understanding some of those genomic events, but I would say at this point, how to utilize that in a way that actually benefits patients, we don't know. So I think it's something to look to the future, but that's again why that may be a little 3 to 5 years down the road and not something right now.
Thank you. Yes, I'm wondering two things actually. One is there anything, it seems like cancer has this common theme of something energizes a cell, it starts to mutate, and then it makes a lot more of itself. Is there anything that you're applying from your research or the research in other cancers that you found helpful? And then I'll give my second question because you may want to deal with both at the same time. It occurs to me, and we're fairly new to this, but something flipped that switch, the first switch, that started to have things misbehave, so to speak. Is there anything that you're seeing there? Because you're talking about reciprocal relationships. Something had to flip the first switch. And is there anything that is maybe holistic or an environment that we have already in our immune system?
Right. So I think I'll take the second question first because I think it might feed into things a little better. Bottom line is we don't fully understand what the initial event is. We do know that when things get super activated and cells are rapidly cycling or turning over, the margin for error goes up a lot. So within what's called the follicle, that's in a lymph node, and within the bone marrow, rapidly responding cells that are making new cells have a high risk of making a mistake. So when you have a juiced up environment, be that from an infection, inflammation, exposures, we spoke a little bit about that before, and the system is on, there's a bigger chance for a mistake. So when a mistake happens, now there's another problem. Your body's built to handle mistakes. It looks at the mistakes, it shuts them down. Why is it that for some reason when you get Waldenström's, a mistake was let by? So number one, the inherent machinery in that tumor cell didn't shut it down. And secondly, the immune system went, you look good, and just let it go through. So two mistakes kind of happened. And so really trying to understand how to switch off that inflammation activation kind of process, how to improve the quality control, the TSA pre-check, if you like, whatever, to kind of work out why the cells, these ones can go through and those ones can't. Those are ways in which we really want to try and work out how to balance what therapy we want to do where. But coming to your second point is, absolutely we borrow information from other areas all the time, and I think that's appropriate. I think it's important to be tumor focused because there are unique things about Waldenström's, but there are also things we learned from other areas where certainly that makes a difference. So for example, MYD88, where there's been a lot of interest, was actually first seen in large cell lymphoma. It's only there about 15% of the time, 90+% in Waldenström's, but that information was borrowed. BTK was first tested predominantly in CLL and mantle cell lymphoma, and when it was really improved, brought across, and now it's approved for Waldenström's because it's highly effective. So certainly I think there's a lot of back and forth between different diseases, and very appropriately so. I think that's the last one, Carl. Right.
That was a really great question. That was an awesome question. There we go. Great question, by the way. I love that question. One final question. I'd just love to hear direct from the source. Out of all of the signaling pathway inhibitors and keeping at bay style treatments that are either out now or are on the horizon in the next few years, which one are you most excited about?
Yeah, so that's a good question. The one I'm always the most excited about is the one that works best. But that's a loaded question and statement, because what does best mean? So one of the challenges is, for me, I would like to see a therapy that is highly effective, cures everybody, and is a finite therapy. In other words, I got the disease, I start treatment, X number of weeks, months go by, and I stop the treatment and it never comes back. That's what I'm shooting for. And hopefully it's just a very short period of time. That would be great. So as we've got promising therapies, many of them right now need to be taken long term. And so the problem with long term is the moment you stop them, it comes back. The problem is you also get long-term side effects, which keep showing up because you have to take things all the time. So that's where we're a little challenged, and that's where some of the older therapies that are a little out of style, if you like, actually have become a little more attractive again, because it's not cool treatment, but it's short treatment. You get 4 months, you stop, never need treatment again, let's say for the next 4 or 5 years. That beats doing something all the time. So all of that to say, there are a lot of promising therapies out there, but they all have strengths and weaknesses. So rather than increase the shares of one particular company right now, I just say that there's a lot of promise, but each one has a weakness. And until we've got one that has none, I think we've got to keep looking.
Would you say that there's a type of treatment style that you prefer more than others?
Now you're going to get my bias.
Yes, that's what I want.
So, and that's just because what do? So I'm a immunology guy. I like the fact that you have resources in your body that could take care of this. And if we could just get your body to behave like it should, we would do much better. So for me, the immunological changes to change how your immune microenvironment goes after the tumor, how your immune system does its thing, that's what I really would like to see. So that's my bias. Is that the best therapy? No, probably not. But that's really kind of where I'm interested. That's just personal interest. Carl, back to you.
Thank you, Dr. Ansel.